What's happened in Virginia's nursing homes is an unacceptable tragedy. But chronic problems that plagued nursing homes long before COVID still exist today, like understaffing and poor infection control. It's time to put the safety and well-being of nursing home residents first. Virginia needs state standards that require nursing homes to have enough adequately trained staff to care for residents. Tell your state lawmaker to support nursing home reform. Virginia seniors deserve better. What's happened in Virginia?
For 55 years, we've been known as Goodwin House, this really trusted brand, but most people think of us as a place that you have to move into. They don't think about all the services we provide or all the ways that we can engage with you as an individual that are well beyond housing. And so Goodwin Living allows us to be much more comprehensive, to expand and allow us to have so many other conversations.
We have this uncanny desire to do more. We refuse to stop.
There are just so many opportunities for everyone as we look to touch each and every senior's life out in the community.
I just like to say that we are honored to sponsor it this year. We have sponsored it for decades. Our founder of Graceful Care, Pat Williams, is one of the leaders and thought leaders for this conference and has been for a very long time. She started Graceful Care in the mid-90s and she named it after her mother, Grace. They're the Graceful Care. We kind of played on that. And we're a small, intimate family run organization, and we usually know the people that we're hiring. And I like to say that it's that our caregivers are the sons and daughters for when the sons and daughters can't be there. That we're there to get them everyone to their doctor's appointments and make sure things are done and that healthy meals are made for them, and the things that normally you would do around the household that just need a little bit of helping hand. We're there for you and have been doing that for decades. I just like to say,
With Synergy, amazing things happen. Even if they've forgotten the recipe, it's the feeling they'll remember. Some things don't have to change, like your sense of style. A gentle nudge is all you need to move forward. We believe companionship fills more than time. The Synergy Effect, brought to you by Synergy Home Care.
All right, folks, welcome to the 36th Annual Caregivers Conference. My name is Steve Gurney, and I am the voice from behind the curtain. If the volume on our sponsor videos was our only problem this weekend or this week, then we're doing great. You're going to hear my voice throughout the next 3 days, but you're not going to see me that often. But who you are going to see are some of your hosts. And today's host is Jessica Fredrickson from Goodwin Living in the Stronger Memory Program. Jessica, I can't believe it's here.
Yeah, it's exciting. We've been planning for this all year. Excited to share some great speakers with you all.
Excellent. Well, I'm going to duck behind the curtain and let you do your housekeeping here. And we're real excited to see everybody, and everybody, is throwing their introductions into chat, and we've got some great speakers lined up. So I'm going to duck behind the curtain, and I'll get your screen back up here. And you just tell me.
Perfect. Thanks, Steve. Welcome everyone to the 36th annual Northern Virginia Dementia Care Consortium Caregivers Conference. I'm Jessica Fredrickson with Goodwin Living. I do our Stronger Memory program and brain health programming, and I'm going to be your MC for today's virtual session. Thank you so much for joining this conference. We hope that you find it informative and valuable. Before we get started, before we really dive into today's event, let's review a few Zoom tips to make this the best experience possible for you. First, if you look to the bottom of your screen, you'll see the Zoom menu bar, and one of the options is chat, which is a great way to introduce yourself to other attendees, to share resources, to make comments about the presentation, and interact with each other. It's important to know that when you click on chat, you must also choose the drop-down menu, all panelists and attendees, so that everyone can see your message. You can minimize and maximize any window in Zoom. So if you find chat distracting, just click on the window and minimize it. A different button says Q&A. The Q&A button is also there in the menu bar at the bottom of your screen. And this is how you ask questions of our speakers. So while our speakers are presenting today, when questions come to mind, this is the perfect place to enter those questions, as that is the first place we are going to be looking for them. Also, we have closed captioning for anyone who would like to see the written words instead of relying only on the audio. So now that those housekeeping tips are out of the way, just to give a little conference overview, the past few years have transformed nearly every aspect of our lives. And although living through a global pandemic has changed our communities and the way we connect with our friends and family, this year's conference theme is Caregiving with Hope and Inspiration. Hope is a powerful thing. It inspires us to do the impossible and help us carry on during difficult times. During this 3-day conference, we'll be bringing you opportunities to learn, encouragement to adapt, and the confidence to thrive as a caregiver. The Northern Virginia Dementia Care Consortium Caregivers Conference is organized each year by a committee of volunteer professionals that represent our dementia community in Northern Virginia. The consortium is made up of professionals who plan and work all year long to bring us this highly anticipated event. Members of the committee represent the following organizations: AARP Virginia, Arlington Aging and Disability Services, the Alzheimer's Association, the City of Alexandria Area Agency on Aging, ElderLink, Fairfax Area Agency on Aging, Fairfax County Department of Neighborhood and Community Services, Goodwin Living, Graceful Care, Inc., Inova Parkinson's and Movement Disorders Center, Insight Memory Care Center, and the Loudoun County Area Agency on Aging. I'd like to recognize the long hours of hard work that the committee members have put into making this conference possible. A sincere thanks to all of you. Also, thanks to Steve Gurney of Positive Aging Sourcebook for all he's done to make this a great virtual experience for everyone. As I mentioned a few moments ago, this is our 36th annual Caregivers Conference, and I'd like to hear from you. In what capacity are you attending the conference? Are you a family caregiver? Are you planning for your own future? Or are you a professional or a volunteer? So you'll see that poll pop up. Without the support of our sponsors, we would not be able to hold this conference. Today's conference sponsors are AARP Virginia, ProMedica, Synergy Home Care, Goodwin Living, and Graceful Care. Thank you so much for your support and helping us make this conference possible. Now I'd like to share some housekeeping pieces of information to make this the best experience possible for everyone. We're meeting online during the next 3 days from 10 a.m. to 12:30 p.m. Each day we'll have different sessions, and the entire schedule is available to view at nvdcc.com. You'll get reminders for all sessions, and you can join using the same Zoom link that you used today. Each day's sessions will be recorded and available for 30 days at nvdcc.com. Handouts for today's session will be posted on nvdcc.com for your convenience, and you'll see that link in the chat box. For those professional attendees wishing to apply to George Mason University for one continuing education unit, those professionals must attend all conference sessions. The link to access the CEU will be provided at the end of the week and costs $50 payable to GMU. One of the most valuable aspects of our Caregivers Conference is our exhibit hall. This year, we're offering a virtual exhibit hall. You can explore, learn, and talk with exhibitors, and you can access our virtual exhibit hall 24/7 for the entire month of November. There are 2 ways to find the exhibit hall. One is to go to nvdcc.com and click on Virtual Exhibit Hall in the menu at the top of the page. The other is to click on the exhibit hall link that we're dropping in the chat. We really encourage everyone to make their way around the virtual exhibit hall. There are over 40 great resources to explore, including videos, links to websites, social media, and more. One of the most fun parts of this conference is the door prize giveaway. Each day we'll be spinning the digital wheel to choose the winners of some great books. Make sure you stick around after our last session to see if you are one of today's lucky winners. With that housekeeping out of the way, I'd like to bring in my consortium colleague, Kimberly Taylor, from the City of Alexandria's Division on Aging and Adult Services, who will introduce this morning's speaker. Kimberly, take it away.
Thank you, Jessica. Good morning, everyone. Today's first speaker is Dr. Peter Rabins. He's the author of The 36-Hour Day, which has helped millions of families through their dementia and caregiving journeys. Dr. Rabin will discuss the process of diagnosing dementia, the latest information on treatment options for Alzheimer's and dementia, identify specific behavioral problems associated with dementia, such as wandering, sundowning, managing challenging behaviors, and the emotional and physical impact of caregiving on caregivers. Dr. Rabins is Professor Emeritus of Psychiatry and Medicine at the Johns Hopkins University School of Medicine. A sincere thank you to Dr. Rabins for being with us today. And with no further ado, I give you Dr. Rabins. Take it away.
Thank you, Ms. Taylor. It's wonderful to be here. I wish we could all be meeting in person, and maybe in the future that'll happen, but Zoom is the best we have these days, so I'm really honored to have been asked to do this. What I plan on doing is talking for about 30 or 35 minutes, and then having the rest of the hour for questions. So if you've got questions, jot them down or put them in the question link here, and then Steve will go through and try to bunch them together in a way that so that will be efficient. But I find that your questions are the most important part of the session. So please, anything that comes to mind that I haven't gone over, please ask, and if I say something that's not clear, ask a question about that as well. What I plan on doing is talking about what I call the 3 revolutions of Alzheimer's disease. The first revolution begins more than 100 years ago, in 1901, when a 51-year-old woman was brought to the large psychiatric hospital in Munich, Germany by her husband. And he reported to the doctors there that for about 6 months, she'd been having trouble, excuse me, doing housekeeping. Doing housekeeping and cooking, things that she'd always enjoyed and done well. But what actually triggered his bringing her that day was that she had become very suspicious and started accusing him of having an affair, which he swore was not true. And this was leading to her becoming physically aggressive toward him. So like many people who have dementia, she had problems both functioning in everyday activities, but also had a change in her behavior that is distressing to others and reflected distress in her. She was admitted to the hospital and evaluated by Dr. Alois Alzheimer. Dr. Alzheimer was already a very well-known researcher and clinical doctor. He had trained first as a psychiatrist and then as a pathologist because he was interested in discovering the causes of mental illness. And he thought that by examining brain tissue at autopsy, perhaps he could find some clues to what caused mental illness. This individual lived 5 years. She was in the hospital for the rest of her life and died in 1906 when her husband agreed for her to have an autopsy. And when Dr. Alzheimer looked at the slides from her brain, he found that throughout her brain were 2 microscopic abnormal structures called plaques and tangles. He was the very first person to describe tangles. And throughout my talk, I'm going to come back to these. So I'll explain a little bit more about what they are later. But the important point is that Dr. Alzheimer knew that these were not normal, that they were not seen in people who were 50 or 60. He also knew that the plaque lesions were often seen in older people, but he was the very first person to describe these tangles. So the original definition of Alzheimer's disease was the dementia caused by plaques and tangles. Now that tells us absolutely nothing about the person. And again, I'll come back to why we didn't really know much about that for a long time. So this was way back in 1906, and he published his first article about it the year later, 1907. And then we're going to skip all the way up to 1968. So 60 years later, Dr. Martin Roth, who is a psychiatrist in England, did a study that seems totally obvious, and it's kind of amazing that it had never done before. He was working also in a large long-term care hospital. He had a lot of patients with dementia, and he wondered about what was the cause. So let me define dementia, because it's a word that I think is sometimes confusing to people. But dementia, very simply, dementia refers to any disease that comes on in adulthood, number one, that number two, impairs 2 or more aspects of thinking, that number three, those impaired thinking abilities lead to a decline in a person's ability to function every day. And number 4, not so important for us today, is that the person is fully alert and awake. So dementia is any disease that impairs multiple aspects of thinking and impairs a person's daily function. So that's a very broad definition. There are over 100 diseases that can cause it. Some are common, some are rare. Some diseases like Alzheimer's disease or Lewy body dementia, everyone who has the disease has dementia, but there are illnesses like lupus or multiple sclerosis, for example, in which only a small number of people develop dementia and most people don't. So we start with that very broad definition. And Dr. Alzheimer, back in 1906, actually in 1901, when he admitted the patient to the hospital, knew that she suffered from dementia, but he had no idea beyond that what the cause was. What Dr. Roth did in 1968 was a large study in which he took all the people in the hospital that he was working in, the long-term care hospital he was working in, asked them to participate in a longitudinal study, meaning that over time they would be reassessed, and that they agreed that when they died, they would have autopsies. So this was just like Dr. Alzheimer's patient. What he did that was different was he went to the local medical hospital and he would get permission from families of people who died from heart attack or cancer, but whose thinking was intact, and they also agreed to have a brain autopsy. So what Dr. Roth did and his colleagues was to compare people who were thinking impaired to people who were the same age, but whose thinking was normal. And when they put all the cases together, they found four things that were and remain quite important. That number one, the biggest difference between the thinking impaired people and the cognitively normal people was that the cognitively normal people had normal brains, and the people who were thinking impaired had abnormal brains. Now, that might seem obvious to us today, but for millennia, really, thousands of years, and up until Dr. Roth in 1968, most people thought that what was so-called senility was just a normal part of life. You got old, you became forgetful and unable to function. Dr. Roth showed that wasn't the case, that if your brain remained healthy, your thinking remained healthy, that if you developed a brain disease that impaired thinking, that's what led to dementia. So that was a very important finding, partly from a medical point of view, but also from a sociological point of view. We no longer even use that word senility because senile, the root of that word, just means old. We realize now that it's diseases that cause decline in people's ability to function. And that was a very important finding that came from this one study. The second thing he found was the same amount of hardening of the arteries in the normal people and in the thinking impaired people. And at the time, hardening of the arteries was the leading theory of the cause of dementia, or again, what was called senility. So this proved that couldn't be the case because many people with normal thinking still had hardening of the arteries in the brain. A third thing that he found was that the number of tangles in the brain correlated with the severity of the impairment. And that's important. I'm going to come back to that toward the end of my talk. But this actually is a very important finding, and that had been ignored for more than a century. And only in the past 10 or 15 years has that come back into recognition of how important it is. I'll just stop at those three, that it's really 1968 that we first recognized, and that's the fourth finding, that what was wrong with the brains of people who had senility or dementia was predominantly Alzheimer's disease. And today we know that about 2/3 of people with dementia have Alzheimer's disease, but that other conditions like dementia with Lewy bodies, frontotemporal dementia, that some people with Parkinson's disease develop dementia. And as I mentioned before, there are a large number of other diseases in which dementia is occasionally occurring. So 2/3 of people with dementia have Alzheimer's disease. The second most common causes are vascular dementia, stroke-related dementia, and Lewy body dementia. And many people have both Alzheimer's disease and vascular dementia together. So that's 1968. If you think about this, the consortium that's supporting this meeting, it was founded in 1984, and it really did take that long for Dr. Roth's results to get into the medical and greater communities. So it's not just 1984 that the Northern Virginia Consortium was founded, but the Alzheimer Association was founded around 1981. The National Institute on Aging began funding Alzheimer research centers in 1982. So it's really only been 35 years or so that we've really understood the importance of Alzheimer's disease. So that's a rather extraordinary change in how we've thought about aging. So that's the first revolution. We really think about aging and the diseases that cause impairment in the brain very differently than we did in the past. The second revolution is what I'd like to call the care revolution, because once people realized that these were diseases that were causing people to be unable to care for themselves, they realized that they should be able to research that just like they researched tuberculosis or cancer. And as people started to look at large numbers of people with dementia, and particularly with Alzheimer's disease, and I'm going to focus on Alzheimer's disease for the next 5 minutes, they recognized that there are a number of commonalities across all people, or most people, with Alzheimer's disease. On average, from first symptom to death, people live about 10 years with Alzheimer's disease. Now, there's a big range. Some people live only 4 years from first symptom to death. Others can live up to 20 years. But the average of around 10 years is where most people's illness falls. And if you look at how those symptoms develop, you can sort of generalize it into 3 stages. Some people have 6, some have fewer, some have more. But I'm able to remember 3 things. So I focus on a 3-stage model, and often these are called mild, moderate, and severe. But the key is how does this develop? And I believe that if we understand the symptoms that the disease causes, we then can start to plan in a rational way about how to care for people. So for the first 3 years or so of Alzheimer's disease, the symptoms that most people notice are difficulty in memory, particularly learning new information, and difficulty in organizing life. And that's called executive function. So people with memory impairment at the beginning can often remember things from the past very well, but it's new information, like they're having a doctor's appointment or who's getting married this weekend, that they have trouble with. And over time, memory gradually seems to go backward, so that at the end of the disease, people can't remember things from their youth. But at the beginning, when people have difficulty remembering what day it is, or even what month it is, or who the president is, they might remember the name of their first grade teacher or the street that they lived on when they were in elementary school. So that's a feature of particularly Alzheimer's disease and the kind of memory impairment people have. And the organization or executive function impairment shows up usually with difficult tasks like doing taxes. People become overwhelmed because that's such a complicated activity. This is often why people have to retire early because of Alzheimer's disease. They may be able to do a number of the tasks at work, but they can't be flexible. They can't learn new things. If there's a challenge, they have problems at work meeting those. And so for the first 3 years or so, those are the major problems. It's in the second 3 years of the disease that people develop problems in language, communication, and I'm going to explain each of these in a little more detail, in doing everyday activities, and in perceiving or seeing the world. Now, from a medical point of view, these 3 symptoms in the middle of the disease all happen to start with A. So they're called aphasia, apraxia, and agnosia. And I partly mention that just to impress you, but it's useful to know that these are seen in other diseases. So many people have known someone who's had a stroke that caused an aphasia. And we know that in general, people with stroke either have trouble expressing themselves, they can't find the words and get them out, or they have trouble understanding what's being said to them. And it may well be a mixture of both. The very same thing happens in Alzheimer's disease. The difference being that in a stroke, it's an instantaneous event. So we know that yesterday somebody could speak pretty fluently and normally, or they could understand what was being said to them. And yet today they can't do that. Because Alzheimer's disease develops so slowly, we often don't remember that the person's not really expressing themselves as clearly as they used to, or they're not understanding what we're saying to them. And so that recognizing that these communication impairments are present can be important, and I'll come back to this in a minute, because a lot of the way we care for people and help them is by understanding what they can't do and what they can do. So the first symptom in the middle 3 years that I've mentioned is language communication impairment. The second one is an inability to do everyday learned activities. Okay, that's that fancy medical word called praxis or apraxia. Now, what does that mean in English? That means trouble brushing your teeth, using a knife and fork, getting dressed. And if you think about these activities, we all learned to do them when we were young, 2, 3, 4, 5. But we don't think about how to do them now. We get dressed without thinking about it. We use a knife and fork without thinking how to do that. We brush our teeth without thinking about how to do it. But these are multiple step activities. We do them automatically. And yet people with dementia, in spite of the fact that their strength is normal, they're not weak in any way, gradually lose the ability in the middle stage of Alzheimer's to do these things. A good example is the difficulty using eating utensils. And if you think about how your children or grandchildren or kids that you know learn to use these eating utensils, remember, they usually start when they're 2 or 2.5, sometime around then, learning to use a spoon. And it really takes months before they can get most of the food in their mouth and swallow it rather than down their face. But gradually, kids master that task of using a spoon. Then they move on to learning how to use a fork. And again, it takes months before they can get peas on that fork and put those in their mouth. And then finally, and it may not be till they're 5 or 6, that we all learn to use a knife. And what happens in Alzheimer's disease is all these activities become unraveled pretty much in the opposite way. So for eating utensils, people first lose the ability to use a knife, then a fork, then a spoon, but they're able to feed themselves with their hands. But eventually, like a newborn, they need to be fed. Okay. The third symptom that develops in these middle 3 years are problems with perception, seeing the world. People with Alzheimer's disease don't see the world the way we do, and that also goes awry in several ways. One of the things that we can all do is really focus our vision on what we think is most important in the environment. So hopefully right now, when you're looking at your screen, you're focused on me, and you're not really seeing the outside of the screen or the rest of the room. Yet when I call your attention to it, maybe now you see the outline of the screen or the rest of the room. But gradually, over a few more seconds, that will go away. And what your brain will be able to focus on is me, I hope. The same thing happens with hearing. If we're having a conversation with someone, our brain is able to focus on what people are saying to us and kind of block out other conversations or music or other noise in the environment. People with Alzheimer's disease, often their brain loses that ability to focus on what's important to them, so that everything becomes, they're sort of bombarded by stimuli. And I think that's one of the reasons why people often seem so overwhelmed. Their brain can't pick out what's important from what's unimportant. A good example is this, are hearing aids that even today, and we've made so much progress in developing good hearing aids, they still have, the hearing aid itself has some difficulty in sorting out between the noise, the sounds we want to hear, and those we don't. So some people complain that hearing aids don't really help them because it just magnifies everything. It's our brain has this amazing ability to visually focus on what's most important. A good example would be if you're driving down the street and there's a child with a soccer ball standing on the curb. You're looking at the street, you're looking at the child, you're looking at the traffic light that's coming up, sort of simultaneously. And in this part of visual perception, our brain is multitasking. It's able to see all of these things. And any one instant, if that child takes a step in the street, all of a sudden we notice that and we jam on the brakes. If the light changes from green to yellow, we slow down, but we still know that that child's there. So in the middle 3 years, these three problems, language communication, doing everyday activities, and perceiving the world, all start to decline in people with Alzheimer's disease. But I'm calling this the caring revolution. Why? Because once we understand what the impairments are, we can begin to think about ways to improve the person's independence. And a good example is the eating utensils problem and how that develops. So if somebody is starting to have trouble using a knife, but can still use a fork and spoon, and we're going to have meatloaf or chicken for dinner, if we cut that up in the kitchen and bring that out on a plate already cut up and put it in front of the person, and they have just a fork and a spoon at their place, they are 100% independent. They can still feed themselves. And that is, again, one of our goals. That's the goal of all rehabilitation: maximize people's functioning. And if they can't do something, try to find a way around it. But we've done something else if we bring the food cut out, and that is we've also preserved their dignity. If you served me a piece of chicken and then said, here, let me cut that for you, and started cutting up food in front of me, I would be insulted. And I think most of you would be as well. That's not true for a 5 or 6 year old, and we do that all the time. So by cutting the food up in the kitchen, we've maximized the person's independence and preserved their dignity. And those are the two goals of our care of people who have all these diseases simultaneously. We always want to maximize their independence and function, and we always want to do what we can to preserve their autonomy and dignity. So you could think about getting dressed. There are a whole variety of other problems that people start developing, but if we use this principle of figuring out what can they no longer do, what can they still do, and how can we maximize their ability to do that, that's one of the primary elements of caring for people with dementia. Let me give you just one other example: dressing. Again, it's very complicated. If you think about how children learn to get dressed when they're 1.5 or 2, they can help us pull up their pants or pull a jersey over their head. And again, over time, they'll learn how to put on a shirt or a blouse, do buttoning, but they may be 5 or 6 before they can zip a zipper, do a belt. So the more complicated activities become later. But in fact, the most complex aspect of dressing is sort of planning how to get dressed, knowing that we need 1 pair of underpants, 1 pair of pants, slacks, or a skirt, a brassiere and a blouse or a shirt. And so when people start having trouble dressing themselves, the first thing that they have trouble with is organizing the act. So if we can lay their clothes out on the bed, 1 pair of underpants, 1 pair of pants or slacks, 1 blouse, etc. They don't need to do that planning, and then they're able to get dressed all by themselves. Again, maximizing independence. Later on, we might have to help them with zippers or buttons, but they can do everything else by themselves. So figuring this out and knowing that it changes over time is part of how we care for people. And again, this caring revolution, this second revolution, has only occurred in the last 50 years or so, as we recognize that all the diseases that cause dementia have unique aspects to them. So dementia with Lewy body or Parkinson's disease with dementia, and the people who with Parkinson's disease develop dementia, those dementias are somewhat different than Alzheimer's disease, So we need to learn about the particular deficits of our loved one and focus on how to get around those problems. And as I mentioned before, how to maximize the person's dignity. So this second revolution, the care revolution, has made a huge difference to the quality of life of people with the disease, has made a real big difference to the care providers, whether it's family members or professionals. And we know so much more about how to care for people now than we did 40 or 50 years ago. That's quite extraordinary. Now, the third revolution is the research revolution. Because once Dr. Roth showed that Alzheimer's disease was a brain disease, not normal aging, researchers started to think about attacking it the way they attack other diseases. Now, if you were a researcher, where would you start? Well, go back to Dr. Alzheimer. What he identified were the fact that people with this illness have plaques and tangles in their brain. Those are the abnormalities, and we've had a 50-year effort to try to figure out what causes them and what we can do to either prevent them or remove them from the brain. In the 1930s, it was discovered that the plaque lesions contain a protein called amyloid, and over time, this has been refined. So we now know that this is a particular kind of amyloid called beta amyloid. And there's a particular form of it called beta amyloid 42 that is abnormal in the brain, that it gets deposited in the brain rather than removed when brain cells die. And the leading theory of Alzheimer's disease is still that the disease is caused by an accumulation of this abnormal protein, beta amyloid 42, and that over time that kills brain cells. So that's called the amyloid hypothesis, and a great deal of research is still focused on that. Dr. Alzheimer was the first person to see those tangle lesions, and we know that these are actually inside of the nerve cells in the brain. And in the 1970s, it was discovered that these lesions are made up of a protein called tau, and that the tau becomes abnormally called phosphorylated, that chemicals link to the tau and make it dysfunctional. And the tau is part of the structure within a nerve cell that helps chemicals move along. So that Alzheimer's disease, we recognize, is a disease of abnormal proteins, the beta amyloid and the tau protein. And it turns out that most of the other slowly progressive dementias, we refer to them as neurodegenerative diseases because people decline usually gradually over time, are all related to abnormal proteins, but they're different. So that in Parkinson's disease with dementia, the abnormal protein is a protein called synuclein. Likewise, in Lewy bodies, and the Lewy body is just a round pathological abnormality described by a student of Dr. Alzheimer named Dr. Levy or Dr. Lewy. And we now know that that's also an abnormal protein. And the same thing is true for frontotemporal dementia, that there are accumulations of abnormal proteins in the brain. So each of the causes of dementia, it seems to be, of the different kinds of dementia are different. And overall, we think that many of them are related to abnormal proteins. Now, what's very exciting, I think, is that from a research point of view, three things now have all come together. And I think the next few years are going to be a particularly exciting time in Alzheimer's research. The first thing that's become clear now is that over the past 10 or 20 years, the rate of new cases of Alzheimer's disease and dementia in general has declined. We don't hear this talked about very much, but it's now been confirmed in many studies that have followed people over long periods of time. So let me repeat that. The number of new cases per person, that is the rate, population rate of developing dementia, has been declining for 20 years. So we're doing something right, and there must be a lot of clues of how to prevent dementia within this finding. We still don't really know why, and this is called the incidence rate, the number of new cases. Why is the incidence rate declining? We don't know. We do know that the number of strokes and heart attacks has declined by about 50% since 1975. That's also a really extraordinary health advance. And we do know that that seems to be due to three different things: controlling high blood pressure, lowering cholesterol, and improved physical activity and diet. And it's all three together that seem to have contributed to this dramatic lowering of the rate of heart attack and stroke. Now, these are still the leading cause of death, so we still need to do more there. But it may be that decreasing those risk factors has also helped decrease the incidence rate of Alzheimer's disease. But there may well be other things that we're doing that have led to that. So that's one really important research finding that I think is not being emphasized enough. The second research advance that I think is just going to come together in the next 2 or 3 years is that we are likely to have a test or a group of tests to diagnose Alzheimer's disease accurately. Even in the best of hands, doctors are only right between 85 and 90% of the time when they make a diagnosis of Alzheimer's disease and then do an autopsy to confirm that the person had the plaques and tangles that Dr. Alzheimer described back in 1906. So the other 15 or 10% of the time, someone has some other cause and they were misdiagnosed. Now that's a problem when you do a study, a drug study, because that means 10 or 15% of the people in your drug study don't have the disease you're studying. Right? That's number one. And number two, as we start developing treatments, we're going to want to give them to people who potentially can benefit. So what are these tests that seem to be coming to the fore and that hopefully will be approved within the next year or two? Well, we have people, not me, people have developed techniques to measure the breakdown products of the amyloid and tau in blood and spinal fluid. Now, it turns out that the levels in blood, at least so far, are not accurate enough to tell us whether someone does have Alzheimer's disease or does not, but that the levels of these proteins, the tau and the beta amyloid in the spinal fluid, are accurate. And again, I think it's likely that tests will be approved by the FDA within the next year or two that will lead to their widespread availability. What is spinal fluid? Spinal fluid is a liquid that bathes the brain. It's made within the brain, and then it circulates so that it's both inside the middle of the brain and around the brain and around the spinal cord. It's being constantly made, and it's one of the ways that the body removes toxins from the brain. And so that the abnormal amyloid and tau proteins get secreted into the spinal fluid. And again, hopefully we will have tests that can measure that. Also in the last 10 to 15 years, brain scans have been developed that can detect the presence of the abnormal amyloid and tau proteins in the brain. These are called PET scans, PET, because they rely on a radioactive particle called a positron, that's the P. So we have ways of measuring how much of these abnormal proteins are in the brain. One of the challenges is that over age 70, many normal people have amyloid protein in their brain, and we don't know yet whether those people will ultimately develop dementia or not. So one of the limitations of the brain scans has been that over age 70, the amyloid scans really on their own are not helpful in making a diagnosis because so many people who are normal also have it. What we're finding now, what has been found, is that the tau protein only begins to accumulate in the brain within a few years of the person developing dementia. So whether that means that tau brain scans will be diagnostic, or whether we'll need a combination of the amyloid brain scan and the tau brain scan, or we'll need some combination of the brain scan and the spinal fluid test, I think that remains to be seen, and that's what's working on now. But the bottom line is we're likely to have an accurate test very soon. And so that will be better than the best clinicians can do in making a diagnosis. And then the final research advance I want to talk about is the likelihood that there will be a few new medications approved in the next year or two for the treatment of Alzheimer's disease. Now, I assume that almost everybody on the Zoom knows that there already is a drug that's called aducanumab, or some people call it aducanumab, that was approved by the FDA, and almost nobody is taking it. Why? The main reason is that there's very little evidence that improves daily thinking or improves people's functioning. What it does do is remove the amyloid from the brain. Now, it is approved, and some people are still being studied, so it may be that in the long range, this medicine slows down the disease, or that people have a later recovery. That remains to be seen. But the other medications that are in study now, both some remove amyloid and target that. A new medicine that targets tau has been shown, or at least the company has, without showing the data yet, has had a release that says that it may also lower the amyloid in the brain and improve people's memory. So we'll have to see how all these drug studies actually, the results that they have. But it seems likely that there will be a few new medicines approved. And I think the negative experience with this aducanumab has convinced people that we need to make sure that it helps patients, not just that it takes amyloid out of their brain, but that people are better off in their thinking and in their daily functioning. I also think we want to see whether these medications can help improve some of the non-cognitive or so-called behavioral or neuropsychiatric symptoms like wandering, withdrawal and isolation, apathy, hallucinations, seeing things that aren't there, delusions, thinking things to be true that aren't, like Dr. Alzheimer's original patient. And we'll have to see what happens with that as well. Okay. So let me stop there and see if we have questions.
Oh, we have a ton of questions, Dr. Rabins.
Great, Steve. Fire away.
Okay, let me, well, let's see. I'm going to kind of start at the top and sequentially go through real quick here. These are great questions. My husband has mild cognitive impairment, which seems to be progressing. What resources are there for caregivers for MCI patients?
Right. I'm so glad you asked that question. Although I mentioned 3 stages of Alzheimer's disease, I think now most people would say, and I agree with this, that there really is a 4th stage, that before people have the dementia that impairs their ability to function, they do develop milder symptoms that we call MCI, mild cognitive impairment, and that's the very beginning of dementia, often Alzheimer's disease, but maybe some other disease. It's probably, now, one of the challenges in making that diagnosis is that over a year from diagnosis, about 25% of people go back to normal. So some people's MCI must be induced by some other physical illness or by depression or some other problem in their life. So we don't necessarily know yet that having MCI in everyone means that they have dementia. But this person's husband is declining, and so that means that he is likely moving toward dementia if he hasn't developed it yet. I think as far as resources, Again, one of the important aspects of identifying this pre-dementia or pre-Alzheimer's stage is that people are developing resources for people. The Agency on Aging and the Alzheimer's Association, I think, are terrific sources of information about available resources in your community. There are support groups for the person who has MCI, and I think many people who recognize that they have a problem really get a lot of help by talking with other people in the same situation. The same thing is true for many care providers, that talking with other people in the same situation helps come up with solutions to problems that you might face, but also helps with the emotional challenges that these diseases bring to us. Recognizing that we're not alone, that other people have gone through this, finding out from other people what resources they found helpful. I think those are very important. So I would turn to those two resources locally. I've written, one of the things that I've done is written 2 books about dementia called The 36-Hour Day and Is It Alzheimer's Disease? Steve's going to put a picture of those in the chat. But the books themselves also do have some information about how to care for people in that early stage.
Okay, great. And one thing I want to remind everybody in the audience is that we have over 300 people here. If you have a resource that has helped you as a caregiver or a loved one or a family or a professional, drop it into chat. This is a community and we can help each other, as Dr. Rabins had said.
Now, Steve, if I can interrupt, now that I've got the questions up, so if I could address a few of them.
Oh, I would love it if you do that.
Great. So here's one question. My family and I would like to have a formal diagnosis of dementia for my mom, but I've heard this won't help the situation. My mom is also in denial and refuses to have a brain scan. What do I suggest? This is a great question. And again, these are important issues. I think first, let's address what's the benefits and the drawbacks of a diagnosis. Again, I believe, and I can't prove this, that if the family understands what the problem is, that's a beginning. There may well be people who don't think there's a problem, or maybe there isn't a problem and she doesn't have dementia. That would be really important to know. So that's one reason to try to get a diagnosis. The second aspect of that is that the diagnosis can tell you what kinds of problems is the person having now. Is it primarily memory? Is it primarily apathy or initiative? Is it difficulty speaking? And often, again, because you're with the person all the time, you don't recognize what the problems are. So from the caregiver's point of view, I think a diagnosis is where you start. I think for a person who recognizes that they're having a problem, nobody obviously wants to get a diagnosis of dementia. No one wants a diagnosis of cancer. With cancer now, we have so many treatments that we wouldn't want to overlook that. But even though we don't have good biological treatments for Alzheimer's disease and frontotemporal dementia, for example, getting a diagnosis, I think, can help the person with the illness recognize that this is not them, they have a sickness. And over the years, I've done research with multiple sclerosis before there were any treatments for that. And it always surprised me how many people who finally got a diagnosis of MS would say, well, at least I know what's wrong with me. So having a diagnosis, it's a start. It doesn't solve everything. So I do think it helps in that way. But the other aspect of your question is that your mother doesn't see a problem and doesn't want to get a brain scan. So I would say first, it's important to recognize that something about Alzheimer's that's unique is that it seems to block people's awareness that they have a problem. So we tend to think of denial as a psychological problem, as someone who can't face a challenge. But there's something about Alzheimer's disease that's unique to it because we don't see this in the other causes of dementia. where people don't know they have a problem. And in some ways, it makes sense. It makes sense that if you think about it, if you're forgetful, you don't know that somebody just told you what event is coming up, for example. So you don't know that you were told. So the fact that you didn't remember it, that's not your problem with your memory. It's that you were just never informed of it. So that tends to fuel it. But I actually myself believe that there's an aspect of the brain related to that perception problem. I mentioned the visual perception, but I also think people have difficulty perceiving or recognizing that they have difficulties in functioning every day. So arguing with her, right, not going to work. We want to respect her dignity. And because there is no good treatment, like there are now for many cancers, I think forcing the issue is a mistake. What can you do? Hopefully she does have a primary care doctor, and that doctor can do just as part of a routine evaluation to make sure that she doesn't have one of the treatable causes of dementia. About 2% of people who present with symptoms of MCI or dementia actually have a treatable problem. It may be medication, it may be depression, it may be a thyroid disease. So that we do blood tests and we do a brain scan. Now, we don't do a brain scan now to diagnose Alzheimer's disease or dementia. We do a brain scan to make sure that the person hasn't had a stroke that's causing the problem, doesn't have a brain tumor. There are a number of causes of brain diseases that can cause the symptoms. One of them is called normal pressure hydrocephalus. Many people have heard of hydrocephalus in young children and newborns. It means that water on the brain, the spinal fluid can't drain normally. Well, some older people develop hydrocephalus as well, and that can be treated. The fluid can be permanently drained, and they can get better. So the reason for the brain scan is to discover other people. So if your mom's willing to go to the doctor and get the blood work and have a physical exam, you can be pretty sure that she doesn't have one of the treatable conditions. And if she won't get a brain scan, fine, maybe in the future she will. And then the final thing I'll say is, this is something that it would be nice if everyone in the family agreed to, so that's one thing. Second is, if she doesn't want it now, I think you back off, and in another couple of months, you bring it up again. And the third thing is maybe to say to her, you know, Mom, I would feel a lot better if the brain scan was normal and I knew there was no trouble. Could you do it for me? And there are some people who say, well, I know there's nothing wrong, but I'll go ahead so that you can feel better.
All right, Dr. Rabins, you've got tons of questions there. I'm going to let you pick one, or I can pick one.
Okay, well, let me go through, because again, I'll try to address the most common ones. How about the different medications used to manage Alzheimer's? Let me just say very quickly that presently, there are two kinds of medicines that are used to treat Alzheimer's disease. One set of medications, Aricept, or donepezil, and rivastigmine, Exelon. These medications increase a chemical called acetylcholine in the brain, and we know that increasing that helps temporarily to improve people's memory somewhat. So about a third of people who take those medicines seem to have a benefit. And it appears that at least for several years, if they stay on the medication, if they have a benefit when they start, that benefit persists. But whenever the medicine is stopped, the person goes back to where they would have been without it. So these drugs don't improve the biology of the disease, they just improve the symptoms. And the same is true for memantine, the other medication that's used right now. There are also drugs used to treat the behavior. They all have really serious side effects, and we want to try everything we can to improve behavior without those drugs. And they also not only don't improve thinking, But if you look at groups of people, they probably make thinking a little bit worse and increase the risk of dying. So we shouldn't be using those unless there's no other cause. Okay. Here's another good question about management. If someone's having a problem, should you encourage them or should you take over for them? Now, the answer to this and many of these questions is there is no one right answer. I think of maximizing care as trial and error. You try something. If it doesn't work 2 or 3 times, then you know it's the wrong thing. So if someone has always loved going to the symphony or going out dancing, and they don't want to do that anymore, they're really reluctant, and you try it a few times, that probably means that they're not really able to do it or to enjoy it anymore. I call it the 3-strike rule. You try 3 times, and if it fails, most likely that means they can't do it. But should you try once? I think for most of us, if we don't try once, we feel that we've made a mistake. Trying and then having it not work, to me, that's part of the process. And sometimes I have been wrong in telling people, I don't think your mom or your husband can do this any longer. And then the person comes back and says, he can do it, and we tried, and he seems to be enjoying it. Okay. The next question relates to someone with stage 1 Alzheimer's who's losing a lot of weight. Overall, people with Alzheimer's disease do lose a little more weight than the average population. One of the good things about aging is that beginning around age 65 or 70, the average person loses about 1 pound a year. But people with Alzheimer's disease lose more than that on average. However, that usually doesn't occur until stage 3. So if someone's losing more than 1 pound or 2 a year, I would really worry that there's some physical disease. And the first step would be to have an evaluation by the person's doctor to make sure that there's not some other bad illness, cancer, for example, that might be causing that. But when people start to develop the swallowing difficulties, and that reminds me, I didn't come back to stage 3. Stage 3 is when people start to develop the physical impairments of Alzheimer's disease. So they start to have trouble walking and with balance, start to have trouble controlling their bladder and bowel function, and start to have trouble swallowing. So losing weight in the 3rd stage is more common. Again, often we can give people softer foods or foods that they can swallow more easily. So there are ways that help some with that. But in stage 1, I would worry very much that unless a person was overweight and snacking all the time so that there's not some other environmental contributor, that there's another disease. Okay, here's one. This is a rare disease, but I think it's worth mentioning, is logopenic primary progressive aphasia, a frontotemporal dementia, or Alzheimer's disease. Okay, so what is this? Well, so some people with frontotemporal dementia develop problems with language, expression, or understanding at the beginning of the disease. Now, remember, in Alzheimer's disease, I mentioned that memory and executive function are the first symptoms. So in frontotemporal dementia, we see changes in people's behavior at the beginning and people's language at the beginning, because the front part of the brain, the frontal lobe, is the part of the brain that organizes behavior and the executive functions that I mentioned before. Other people develop frontotemporal dementia in what's called the temporal lobe, which is the part of the brain under our temple. And that's where, on the left side, for most people, language is located. So some people at the beginning of a dementia just can't get the words out, and that gradually gets worse. It turns out about 80% of those people at autopsy have frontotemporal dementia, and 20 have Alzheimer's disease. and it often, we can't be sure. But this is where the PET scan that measures glucose in the brain is helpful, because glucose is what brain cells use as a fuel, and people with frontotemporal dementia tend to have decreased ability to utilize glucose in the temporal lobe or the frontal lobe or both, whereas people with Alzheimer's disease have a problem more broadly in what's called the parietal and temporal lobe in this area. So they can be distinguished often by PET scan. Okay, here's somebody writing about Parkinson's disease with severe dementia. She does not have Alzheimer's. She has trouble walking, cutting food, remembering proper names, but knows all the grandchildren's names and birth dates. Is this pairing of Parkinson's dementia common, or are we dealing with an unusual combination? It's another great question and a tricky one. I've mentioned before Lewy body dementia, or dementia with Lewy bodies. So again, these Lewy bodies are a circular abnormality in the brain discovered by Dr. Levy or Lewy. He discovered it way back around 1912 and described it in people who had Parkinson's disease. And we know that people with Parkinson's disease develop these Lewy bodies in a very particular area of the brain. And as the Parkinson's disease gets worse, they develop more of these Lewy bodies. I mentioned that they're a specific protein called the synuclein protein. Well, some people develop the same abnormality, these Lewy bodies, not in the center of the brain, the substantia nigra, as in Parkinson's disease, but in the outside part of the brain, the cortex. And it was discovered in the late 1980s that some people have only these Lewy bodies outside, in the outside part of the brain, and they too can have a dementia that doesn't have the plaques and tangles of Alzheimer's disease. It becomes complicated because many people have both. They have both Alzheimer's plaques and tangles, and they have the Lewy bodies. So everyone with Lewy body dementia has dementia. As far as Parkinson's disease is an illness in which people have a tremor, they shake in their hands, they're slowed down, and so they move very slowly. They have trouble thinking quickly, so they also have a slowdown in their thinking. They have balance problems, and they are very stiff. Now, Parkinson's disease traditionally has been thought not to have dementia, but we now know, because our treatments are so much better than they used to be, that people who live with Parkinson's disease for 10 or 15 or even 20 years often develop dementia. Sometimes that's coincident Alzheimer's disease, but we recognize that they too that people with Parkinson's disease can develop dementia due to Parkinson's, that is due to these Lewy bodies and that abnormal synuclein protein. Now, so how do we make the distinction? Well, we look at, from a clinician point of view, we look at the kinds of problems that a person is developing. Again, I go back to what I mentioned, that Alzheimer patients have trouble with memory and executive function at the beginning. People with Parkinson's disease can have some memory problems, but interestingly enough, if you give them time, they will often remember the fact or the answer to the question. So it's not as if the memory isn't gone or hasn't been developed in their brain. It's just that they have trouble accessing it. People with Alzheimer's disease have trouble learning new information. So there are psychological tests that can distinguish from that. People with Parkinson's disease who have trouble with walking, cutting food, those are those everyday activities I mentioned. Now, the physical aspects of Parkinson's disease can interfere with cutting food, for example. So the difference is that, does the person know how to use a knife? Does the person know how to hold the knife? But it's just that because of their shaking or their stiffness, they can't do it. That's due to Parkinson's. But if they don't know how to hold the knife or don't really know how to use the utensils, that's more likely an Alzheimer's symptom. I do want to say that although I think diagnosis is very important, it's not everything. In the end, we come down to the same principles of treatment for all these diseases. We try to identify what a person can't do, what they can do, and we want to maximize what they can do and minimize what they can't do, and try to figure out a way, again, as I've said already, to maximize their independence and dignity. So sometimes we can't know what the diagnosis is, even after several years, but we can still care for the person in a way to make their life better and our lives as caregivers better. Here's a tough one. My neighbor has dementia. We got her a social worker, contacted adult services, but the county didn't think it was that bad. She had bad memory, kept getting lost, didn't pay bills, saw dead people. Once she was arrested, she traumatized me by breaking into my house, hiding in my front and backyard. Is there any help for the person and for this neighbor as well? Well, first, I mean, it's such a sad situation, but a person who has no family, I think you have to go back to adult protective services. And ideally, they may, if it's their evaluation, recognize that she's no longer able to make decisions for herself and will need to be cared for. I think that's the best we can do. This is not a rare situation. About 20% of people with dementia live alone, and many of them have no family members and are helped by neighbors, just as you are. Is there any help for you? Well, I think I can see why this is so traumatizing. And I think if you're really distressed by it, I think this is having a counselor, whether it's a minister, rabbi, or somebody from the clergy, maybe it's a social worker who works for the Agency on Aging, or somebody in private practice, to go over the trauma, discuss it with you, talk about why it was so hard and what you can do in the future. I think that might help a lot. Here's one that deals with an ethical sort of issue. Should a person with dementia undergo colonoscopy? While the use of propofol, the anesthetic, is low risk, it's still a risk. And if polyps are discovered and it takes 7 to 10 years to develop cancer, maybe the test shouldn't be done because the person's not likely to live that long. Well, I think you have all the facts. There's no one right answer. And I think you partly want to think about what would the person do if he or she could make the choice and knew all these facts. And so that's called, so you would be substituting, you would be actually representing their judgment. But if you're not sure and they haven't had an advance directive to help you, again, I think you make the best decision based on these facts. Anesthesia is not a likely contributor to dementia, although I think that's not fully clear. But I think you have all the facts. So you just have to recognize that there's no one right answer. And this happens with so many of these kinds of difficult ethical issues.
This breaks my heart, Dr. Rabins, but we've got a transition here. Do you want to glance at the questions and maybe pick one last one to address?
Yeah, and it's going to take me 2 minutes, so I'm going to go over 1 minute. I apologize, but everybody has this question, which is it genetic or hereditary? And it turns out to be a very complicated question, but it's very timely because this is relevant to many diseases that we are at risk for. Most of us learned in middle school or high school about genetics, and we learned what's called Mendelian genetics, that they're dominant genes and recessive genes. And if you remember, if you inherit the dominant gene, you're going to get whatever that trait is, whether it's blue eyes or dementia. And that if it's a recessive gene, you have to inherit one copy from your father and one from your mother, so both parents. We've learned in the last 15 years that there's actually a much more common, different kind of genetics. And that is that for most common diseases, many genes contribute only a small amount. Now, this isn't just true for disease. So for example, the most extreme example, height. Height is one of the most genetic traits that there is. There are probably 700 or 800 genetic genes that contribute to how tall you are. No one of them contributes close to a percentage. And this is probably true for most common things like diabetes and high blood pressure. And it turns out that for Alzheimer's disease, there are two other kinds of genetic contributors. We all have a gene called the ApoE gene. We still don't quite know what the protein that this gene makes does, but this gene comes in three different forms called 2, 3, and 4. And we know that if you inherit the 4 form of the ApoE gene, that you triple your risk of getting Alzheimer's. So how does that translate to reality? Well, at age 80, we have a 20 or 25% risk of having Alzheimer's. We know that just in the population, about a quarter of 80-year-olds have dementia, mostly Alzheimer's. If you have the ApoE gene, you're about 35% likely to have Alzheimer's. And if you don't have that gene, you're 15% likely, okay? And then there's another 25 to 50, the number isn't clear yet, of genes that together contribute 6 to 8% of the genetic risk. So overall, Alzheimer's disease is around 50%. It might be 40, it might be 60 or higher, but around half of the risk for Alzheimer's is genetic, which means that a third or a half is non-genetic. Because we don't have ways to prevent it, and we don't really fully understand all the genetics, I'm not sure what we do with that information. Some people want to know that they have the ApoE4 gene, and I think to get a 23andMe test, that's fine. The question to ask yourself is, what would you do differently if you knew you were at higher risk of getting it? And if you would start smoking, that's not good. If you would retire a year or two earlier while you're healthy, maybe that would be a reason to get tested. So it's a question on everyone's mind, and it may, and I'll finish up by saying, this may well relate to treatment in the future. We know now that for many cancers, specific genetic markers tell us which kind of drugs to treat people with, or what kinds of treatments to offer, not just drugs. So it may well be that we're going to have multiple treatments for Alzheimer's disease, multiple treatments for Parkinson's disease that target both genes and the abnormal proteins. But right now, that's not the case. So thank you for listening. I'm sorry we couldn't get to all the questions. They're all wonderful, and I wish you the best of luck with the meeting.
They are, and I'm going to make sure that we download and copy all of these questions to the committee, and hopefully we can share, collaboratively share some answers with folks, because we really appreciate everybody's feedback. And Dr. Rabins, it's truly been an honor to have you as our keynote and for the first day kicking off the 3-day conference. We've added some links to get your books, and we really thank you for doing this today.
Thanks, Steve. And I should say, I'll plug the books, but we've tried in the book to answer many of these questions. So thank you for sharing that. And thanks everybody for your applause. I appreciate that.
I know, isn't it funny? We don't hear it, but we see it.
Right.
Applause now.
Fun. No, it's like going like this. I think that's great.
So, okay, well, great. Thank you, Dr. Rabins. And for those in the audience, we are going to come back on in, let's take a 5-minute break, okay? So around, if you want to take a break, come back at 11:25. We're going to play some videos from our sponsors here. And then we will come back with Mary Fridley and a presentation, Navigating Dementia in Life with Creativity, Humanity, and Joy. So I'm gonna put up the sponsor videos, and we will see everybody in about 5 minutes. Okay, just do this one more time here.
What's happened in Virginia's nursing homes is an unacceptable tragedy. But chronic problems that plagued nursing homes long before COVID still exist today, like understaffing and poor infection control. It's time to put the safety and well-being of nursing home residents first. Virginia needs state standards that require nursing homes to have enough adequately trained staff to care for residents. Tell your state lawmaker to support nursing home reform. Virginia seniors deserve better. What's happening?
For 55 years, we've been known as Goodwin House, this really trusted brand, but most people think of us as a place that you have to move into. They don't think about all the services we provide or all the ways that we can engage with you as an individual that are well beyond housing. And so Goodwin Living allows us to be much more comprehensive, to expand and allow us to have so many other conversations.
We have this uncanny desire to do more. We refuse to stop.
There are just so many opportunities for everyone as we look to touch each and every senior's life out in the community.
I just like to say that we are honored to sponsor it this year. We have sponsored it for decades. Our founder of Graceful Care, Pat Williams, is one of the leaders and thought leaders for this conference and has been for a very long time. She started Graceful Care in the mid-90s and was she named it after her mother, Grace. They're the Graceful Care. We kind of played on that. And we're a small, intimate family run organization, and we usually know the people that we're hiring. And I like to say that it's that our caregivers are the sons and daughters for when the sons and daughters can't be there. That we're there to get them everyone to their doctor's appointments and make sure things are done and that healthy meals are made for them, and the things that normally you would do around the household that just need a little bit of helping hand. We're there for you and have been doing that for decades.
With Synergy, amazing things happen. Even if they've forgotten the recipe, it's the feeling they'll remember. Some things don't have to change, like your sense of style. A gentle nudge is all you need to move forward. We believe companionship fills more than time. The Synergy Effect, brought to you by Synergy Home Care.
Okay. Well, what a way to open up the conference, right? That was an amazing presentation from Dr. Peter Rabins, truly a pioneer in dementia care. with his innovative book, The 36-Hour Day, and that was a wonderful way to kick things off. So I am going to drop behind the curtain again and turn things over to Jessica here. And what I want to do is I am going to